Let's jump right into this rapid-fire explainer on the essentials of postoperative management and thyroid complications. We've got a lot of ground to cover, so let's hit it.
Question 1. A patient develops a tension hematoma at the surgical site within 4 hours after a thyroidectomy. So, what's the classification of this postoperative complication based on that time frame? Is it A, urgent, B, immediate, C, early, D, late, or E, delayed?
And the correct answer is B, immediate. Surgical complications are always chronologically categorized based on the time elapsed since the operation. A post-thyroidectomy tension hematoma almost always forms within those first 6 hours, right? Basically due to reactionary hemorrhage. The critical timeline you got to remember here. Immediate occurs within 6 hours. Early falls between 6 to 72 hours, think atelectasis or early wound infections. And late, well, that refers to complications developing more than 72 hours post-surgery.
Moving right along, question 2. All of the following are advocated by the Enhanced Recovery Protocol, or ERAS, except A. Early physiotherapy, B. Early mobilization, C. Early hydration, D. Administration of opioid analgesia, or E. Planning discharge before admitting the patient to the hospital.
The answer here is D, administration of opioid analgesia. Okay, so the entire clinical goal of an ERAS protocol is literally to spare patients from the adverse effects of opioids. We're talking about dodging respiratory depression, profound sedation, and postoperative ileus. Instead, we lean heavily on regional nerve blocks and non-opioid meds. The standard ERAS mandates you absolutely need to memorize are early planned physical therapy and mobilization, prompt oral hydration because we want to preserve gut function, and discharge planning that starts before the patient is even admitted.
Question 3. When should a patient be mobilized after an elective abdominal surgery? A. In the post-anesthesia recovery room. B. The same evening of the operation day. C. After the first post-operative day. D. After the second post-operative day. Or E. After the third post-operative day.
Correct answer is B, the same evening of the operation day. Modern ERAS guidelines really hammer home early mobilization. Why? Because it preserves skeletal muscle function, stimulates gastrointestinal motility, and massively reduces bed rest complications, things like deep vein thrombosis, hypostatic pneumonia, and urinary retention. The sequential progression of mobility is the key takeaway here. You transition systematically from passive movements or sitting out of bed on the actual day of surgery, straight to active standing and walking in the hallways on the days that follow.
All right. Question 4. What's the most common presenting symptom of a pulmonary embolism? A. Dysphagia. B. Respiratory distress. C. Pleuritic chest pain. D. Tachycardia. Or E. Hypotension.
The answer is B, respiratory distress. Acute pulmonary embolism classically presents with a sudden onset of dyspnea, and we see this documented in over 92% of affected patients. It's super important to contrast the clinical sign versus the symptom here. Dyspnea is the most common subjective symptom, whereas tachypnea is the most common objective physical sign. Also, you've got to recognize the massive PE profile. Basically, a central embolus causes right ventricular strain, and that presents with systemic hypotension, jugular venous distension, and an elevated central venous pressure.
Hitting question 5. Which of the following is the most alarming sign in a case of pulmonary embolism? A. Altered mental status or confusion. B. Dyspnea. C. Abdominal pain. D. Chest pain. Or E. Tachycardia.
It's A, altered mental status or confusion. The absolutely crucial point here is understanding the underlying mechanism. Severe pulmonary vascular occlusion actually limits left ventricular preload, which drops cardiac output and leads to critical cerebral hypoperfusion. And this whole situation is exacerbated by right-to-left shunting through a patent foramen ovale as those right atrial pressures spike. So remember these core adverse markers: cardiogenic shock, acute altered mental status, and a history of active malignancy. Those are, for sure, the strongest clinical predictors of poor outcomes in an acute PE.
Next up, question 6. Which of the following is the best investigation to diagnose a pulmonary embolism? Is it A, CT pulmonary angiogram, B, a VQ scan, C, a chest X-ray, D, a D-dimer test, or E, a chest ultrasound?
The correct answer is A, CT pulmonary angiogram. CTPA is non-invasive, it's highly sensitive, and it gives you direct visualization of intraluminal clots. Sometimes it'll even show that classic polo mint sign on transverse views. But, keep its diagnostic limitations in mind.
VQ scintigraphy is really an alternative reserved strictly for patients who absolutely cannot undergo a CTPA, like if they have severe contrast allergies, are pregnant, or have advanced renal insufficiency. And as for D-dimer tests, well, they're virtually useless for diagnosing a postoperative PE simply because surgical trauma inherently elevates D-dimer levels across the board anyway.
Let's look at question 7. The most common cause of respiratory muscle paralysis causing hypoventilation during recovery after extubation is A. Hypoxemia, B. Hypothermia, C. A high dose of muscle relaxants, D. Opioids, or E. Smoking addiction.
The answer is C, high dose of muscle relaxant. Postoperative hypoventilation right after extubation is most commonly caused by residual neuromuscular blockade, usually from an unreversed or just a high dose of intraoperative muscle relaxants. Visually contrasting the two main causes is pretty vital here. Neuromuscular depression leaves the patient floppy, anxious, alert, and basically suffocating with these uncoordinated rocking boat-type respirations. Conversely, narcotic depression makes the patient somnolent. They display slow, rhythmic breathing and are completely unconcerned about their hypoventilation.
Question 8. A 36-year-old female who underwent a subtotal thyroidectomy complains of shortness of breath 2 hours after the operation. So what is the most likely cause? A. Tension hematoma. B. Bilateral recurrent laryngeal nerve injury. C. Tracheomalacia. D. Injury to the trachea. Or E. Pulmonary embolism.
Correct answer is A, tension hematoma. This is a reactionary hemorrhage that typically develops within a 2 to 6 hour window after neck surgery. Basically, blood accumulates and generates this extreme hydrostatic pressure that literally compresses the flexible trachea, which causes rapid upper airway obstruction. Recognizing the timeline is the clinical pearl here. Bilateral recurrent laryngeal nerve injury causes immediate stridor and severe respiratory distress right after extubation. But a tension hematoma, that takes a few hours to collect and gradually compress the airway.
Moving right to question 9. A 50-year-old female patient having a huge multinodular goiter for the past 14 years underwent a total thyroidectomy. Just after extubation, the patient developed dyspnea with visible supraclavicular and intercostal retractions. What is the most likely cause of the patient's respiratory distress? A. Tracheomalacia, B. Tension hematoma, C. Right recurrent laryngeal nerve palsy, D. Injury to parathyroid glands, or E. Superior laryngeal nerve palsy.
The correct answer is A. Tracheomalacia. This happens because of the structural loss of rigidity in the tracheal cartilage rings, which follows years of chronic mechanical pull by a large goiter. So upon extubation, the negative inhalation pressure causes the flaccid tracheal walls to collapse inward. The immediate mechanical rescue absolutely mandates continuous positive airway pressure or reintubation to pneumatically splint that collapsing airway open. The diagnostic threshold is then confirmed via a dynamic CT or bronchoscopy showing a collapse of greater than half of the tracheal lumen.
Question 10. A 20-year-old woman undergoes a total thyroidectomy for carcinoma of the thyroid gland. On the second postoperative day, she begins to complain of a tingling sensation in her hands. She appears quite anxious and later complains of muscle cramps. What is the probable cause of her symptoms? A. Hyperkalemia. B. Hyperventilation. C. Hypocalcemia. D. Parathyroid removal. Or E. Damage to the thyroid pedicle.
The answer is D, parathyroid removal. Tingling, anxiety, and muscle cramps on the second postoperative day all point directly towards severe hypocalcemia. This is caused by permanent devascularization or the accidental removal of the parathyroid glands during a central neck dissection. Definitely remember this critical risk window. Postoperative hypocalcemia typically manifests pretty dramatically 2 to 5 days after a total thyroidectomy operation. Finally, question 11. A patient complains of hoarseness of voice after a thyroidectomy. He has no difficulty in breathing. Damage to which of the following structures has occurred? A. External laryngeal nerve. B. Recurrent laryngeal nerve. C. Superior thyroid artery. D. Inferior thyroid artery. Or E. Parathyroid glands.
And the correct answer is B. Recurrent laryngeal nerve. Unilateral injury paralyzes the ipsilateral vocal cord, which causes it to rest in a paramedian position. This results in immediate hoarseness without airway obstruction. The absolutely critical takeaway here: unilateral injury causes hoarseness alone, but bilateral recurrent laryngeal nerve injury paralyzes both cords. That causes them to collapse together and completely obstruct the airway, which leaves us with a pretty intense clinical thought. When extubating a high-risk thyroidectomy patient, are you truly prepared for the airway to vanish right before your eyes?